Hey everybody, so this week we are covering older adult exercise. We'll talk about this first part. I'm really going to gloss over, really go back into detail. I'll post all the slides so you guys can look at it from a text standpoint. The emphasis I think I really want to get out to you guys this week is more in the testing and the prescription and the rapport with older adults. So with that, we're going to start now with aging. So our objectives is to gain an understanding of the physiological adaptations associated with aging. So from cardiovascular, pulmonary, musculoskeletal, neuromuscular. From there, we're going to understand the effects of physical inactivity, sedentary behavior, understanding the effects of exercise as we age. So what's going on in all of those physiological adaptations. Talk a little bit about, actually a lot about associated fall risk and factors that play into that, and then learn how to conduct each component of the senior fitness assessment and talk about exercise prescription after that. So we're going to talk about what is aging. When we think about it, really, what does it come down to? Those irreversible changes, biological as well as physiological changes that occur throughout somebody's lifetime. We know there are a lot of things coupled together that actually affect how we age, some of those being environmental, genetic, and lifestyle choices. So family history plays a big role in how we age. Environmental factors such as geographical environmental factors, food and resource environmental factors, as well as lifestyle considerations such as occupation, job, lifestyle choices in those. Do you exercise? How do you eat? Do you drink? All of those things affecting how we age. You can see turning right in 5 miles. I better signal now. This is going to play, I think, a big role in how we look at the perspective from an older adult standpoint. Also taking into consideration who is an older adult, right? So we've got individuals greater than or at least 65 years old, or individuals within that 50 to 64 year range before that are clinically significant, that have conditions or physical limitations that affect some sort of movement, fitness, or physical activity. It's a diverse group of all ages and physiological capacities. Here's actually my dad doing some CrossFit stuff. I think he's lifted more than I have at this point. I think he's approaching 60 right about now. And I think across the board, we're all going to end up running into, especially when you guys move out into the field, you're going to start running into several individuals who actually fall in this category, and they're coming to you because their doctor told them to, because it's pertinent to their health and fitness, because they're starting to realize change and independence. And they're going to be people, your aunts, your uncles, your parents, neighbors, friends, that all kind of fit into this category now as you guys move into that career world. So with our fitness age, first our chronological age, you can see here, let's call him Jim. Right now his chronological age, we can even go with Dave. Chronological age is 50, compared to his bio age is 35. So all the green marks are going to be measures of health and fitness. So VO2 max we know is in a green zone. We've got his blood pressure that's about 116/64, which is really good. His core endurance, better than mine. Flexibility, his push-up, we can see his nutrition scores. The ones in gray are going to be lifestyle choices that actually affect his chronological age as well as his bio age. We can look at triglyceride levels, glucose levels, so blood testing, but health and function status are often better indicators of an ability to engage in physical activity than their chronological age. So those medical history forms, those questions that you ask in intake about your clients, even the things that you learn throughout your first few sessions with them, they're going to tell you things that they omitted in their intake. Those are all going to play a huge role on how you move forward engaging them in physical activity. In talking about effects of those bio age markers and the chronicle age, we can talk a little bit more about skeletal muscle decline over the course of our aging, over the course of our lifespan. First being atrophy, which is going to be just a decrease in the cross-sectional area of a muscle. So you've got the belly of your bicep, that entire cross-sectional area is minimizing or getting smaller, would be indicative of atrophy. Next being hypoplasia. which is going to be a loss of those muscle fibers within those cross-sectional areas, right? So the fibers themselves are getting smaller, but after time, you're going to start to lose some of those muscle fibers themselves. Eventually, this is, I think, what we talk about in obesity populations, the older adult population, this term being sarcopenia, which is going to be that loss of muscle mass and eventually strength. So it's physical disabilities, poor quality of life, and can lead to ultimately death in very frail or clinically diseased populations. We see sarcopenia actually a lot in our prostate cancer patients. So the ADT treatment that they're on is testosterone suppression. So they're losing muscle mass and they're losing strength. So they're losing functionality in daily activities. So it leads to poor quality of life. End of life moves them more into non-independent living, which puts them at risk for comorbidities and or death. We know nervous system contributes to sarcopenia, so we have this motor unit remodeling. We know that type 2, which is our fast twitch or our power muscle motor unit, becomes de-innervated because of the lack of movement inducing those kinds of type 2 fast twitch as we age. We stop participating in fast movements, we stop participating in power movements, just in our everyday activities. We stop running around, playing recreational sports. We move into slower ways of life, walking to places, not riding bikes, things like that. We have this type 1 or our slow twitch motor unit starts to sprout through this axonal sprouting, and it will convert those type 2s, those inactive type 2s, and phase them into type 1 muscles or motor units, if you will. What this does is leads to more of a homogeneous motor unit. Having less type 2 and more type 1 puts us at risk for strength, right? Loss of muscle. Well, we're losing muscle. We're losing that adaptability of our muscles to handle higher movements, fall risk movements, or safety movements, if you will, if we're losing those type 2 muscle fibers. Another thing we see with that satellite cell function, we know that they're responsible for growth, repair, and adaptations. As we age, we see a significant loss of these satellite cells and their function, which leads to an impairment in repair of muscle fibers, impair function of that repair, and it decreases our adaptation to any changes that are happening or that degradation, right? So we know building muscle mass, these satellite cells really help us regrow and repair those micro damages that happen on a muscular level. As we age, we lose that ability to have as much of a success in that without that satellite cell function. Again, this downward path, there's 40 to 50% decrease in muscle mass between the ages of 30 and 80. There's a 4% decrease per decade at ages 30 through 50. So when we turn 30, there's going to be some percent decrease or some physical adaptations leading towards a decrease in physical function, right? Depending on what you do, you can decrease that percentage, but there's still going to be some sort of decline as we age. That is going to be atrophy. With atrophy, again, that's just the loss of cross-sectional area. So our fibers are getting smaller, we're losing some of those type 2, or they're moving into type 1 muscles, so we're not engaging them as much. And then there's about a 10% decrease in muscle mass at the ages 50 through 80. So as we get up towards that top of the hill at 50, we see a larger decrease in that muscle mass, and that's going to be more due to the atrophy and the hyperplasia. So now our cross-sectional area is getting smaller, our muscle fibers are getting smaller, and then we're also losing the amount of muscle fibers that we have in that cross-sectional area due to inactivity and not using those. So with aging, there's a decrease in ability to sustain and produce that power, which we talked about. We see a significant reduction in muscle strength, which leads to a decline in functional capacity. And then we see weight loss or this muscle atrophy correlate with increase in chronic diseases such as strokes, diabetes, arthritis, and cardiovascular disease. We see those power declines. It's faster than overall strength, right? We see a slower decline in strength because we're losing those type 2 and they're moving to type 1, which still allows us strength, but it significantly reduces our power. We have limited mobility again, which is going to significantly increase incidence of accidents and falls from either muscle weakness, fatigue, and poor balance, right? We're losing that neuromuscular control as well. Here with the neuromuscular control, the combination of the nervous system, we see lapses in that synapse. We see degradation in some of the proteins in that synapses, I guess, if you will, which is going to lead to diminishing capacities. So there's a decrease in nerve impulse transmission, the way that we signal from our brain to our muscles. We have degradation in myelin tissue and things like that. Again, this results in compromised daily living activities. It decreases lower quality of life. Again, that neuromuscular control at the muscle tissue level, we see a lapse in transmission there as well. There's a decrease. What we'll see mostly is a decrease in that gait velocity, stride length. We see differences in pelvic rotation, ankle and plantar flexion when walking. So this significantly changes posture. It significantly changes safety when walking, especially if they have such a decrease in this either gait stride or velocity. It doesn't allow them the proper movement to safely move about in their daily activities. So again, this is a review. I would take a second to pause on this slide and ask you guys what each of these are as a reference. We're going to jump through. I think you guys can read this as well. So we know our heart rate, we know what our stroke volume is, we know what our cardiac output is, so it's in liters per minute, how much blood we're pumping to the body in liters per minute. We have our AVO2 difference, which is going to be the difference in oxygen from the arterial to the venous side. So how much oxygen, again, is that oxygen consumption, how much is the muscle uptaking at that level. So what we see in changes as we age to the max heart rate, we know that it's going to decrease in age, especially if we have predicted, right, 220 minus age. The older we get, the lower our max heart rate predicted is going to be. The reason is there's a decrease in medullary sympathetic outflow. So what that is we know that the neuromotor control of the heart rate, digestion, and respiratory rate, there's a decrease in that outflow. So if there's a decrease in that neuronal stimulation, we're going to see a decrease in that heart rate. We also know that there's some, I think, research out there on changes in cardiac myosin. So we know that the myosin controls contraction through the cross bridges. So if there's changes in that, we see delays or decreases in that contractility of those cross bridges in the cardiac muscle. Breaking it down from stroke volume, we know the changes occur because of the decreased elasticity of the aorta and the arteries. So there's a decreased elasticity, it's firmer, it doesn't allow for as much blood flow or blood accumulation in those. There's a decrease in left ventricular systolic and diastolic myocardial function. What we see is stroke volume contributes actually 50% to the reduced VO2 that we'll talk about, I think, on the next slide. Our cardiac output, this is just outlining the changes that we see. So if we have a decrease in stroke volume, we're going to have some sort of decrease in cardiac output coupled with a decrease in heart rate, right? We know our heart rate's decreasing as we age, or our max predicted. So our resting cardiac output for a 25-year-old, 65-year-old, and an 80-year-old, especially if our heart rate and our stroke volume are decreasing, we know our resting doesn't necessarily change, but if our stroke volume is decreasing, we see a significant decrease in our resting cardiac output as we age, right? Lastly is our AVO2 difference. So it's a loss of muscle mass accompanied by a loss of blood flow to local area. So there's a decrease in capillary beds to muscle fiber ratio. So there's less blood flow to those areas. So there's less surface area of that oxygen transmission between the blood and the arteries to the muscles themselves. We'll talk about ways that we can increase this capillary redistribution and increasing that, right? We know with resistance training and aerobic training, we can expand our capillary beds and things like that, right? But this is going to be where or why some of that AVO2 changes or decreases over time as we age. So why exercise, right? This is going to be the graph that, like, I would ingrain in the way that you think about prescription and the way that you think about the clients that you're working with. So we've got early life, growth and development. We've got our muscle mass and strength on our y-axis. We're going to see an exponential growth in that over our early life. as we hit adult life, right, let's say 50 to 60 or even 30, right, we know that there's some sort of decrease in muscle mass or muscle strength at that age 30 mark. So where you see that blue line start and that gray line deviate on a normal trajectory without resistance training, without physical activity, we see a significant and a drastic decline as we age. Especially in our older adult life. So let's go 50 to 60, 65 to 70. I think we get to eldest adults, 75 and above, even 80, that have significant impairments, frailties. The difference in some sort of daily activity, physical activity, and or repetitive or planned exercise is that difference from the blue line to the gray line. So we significantly change the trajectory of a severe decrease or severe slope in changes in muscle mass and strength over the course of our lifetime. A lot of times it keeps us actually out of that disability threshold, which is huge, huge, huge for older adults, because we know one of the main reasons they move from independent living to dependent living is a loss of muscle mass and strength. If we think about how many of you guys don't think about getting up and out of a chair, right? You're not using handrails, you're not struggling to do it, you have control lowering yourself back into the chair. If you can't get up and out of a chair, you cannot go to the bathroom, you can't get out of bed most days, right? So you significantly require a lot more help in your daily activities. So again, that blue line is where we come in as exercise physiologists. How we get them to do that, we'll talk about in prescription, but a lot of it's behavior, how you approach, the rapport you build. They're not used to this kind of exercise, right? Resistance training for them, they used to do labor-intensive jobs over the course of their adolescence and through the years that they've had in the workforce. So resistance training for them looks a lot different. We know that picture on the left is exactly what I'm talking about, on that dependence of somebody else to help you out of that chair, as opposed to having some sort of assisted exercises that you can do with supervision, right? So what that looks like, so we know adaptations to resistance training include an increase in muscle mass, strength, and endurance, right? We see this again, improved functional capacity and quality of life. Quality of life is going to be key, especially with this population as well. We see reduced signs and symptoms of arthritis. One of the things with arthritis and considerations is they're going to come to you with pain, and that pain they're going to not want to do a lot of different things. But over the progression of your exercise program, that pain should reduce. The more movement, the more mobility they have, the more exercises they're doing. There's significant reductions in pain symptoms and things like that of arthritis itself. So it's kind of getting over that hump. Adaptations to resistance training, restoration of balance and reduction of falls, again, huge, huge, huge. And mostly in women, we know that resistance training, we see adaptations in bone, so strengthening of the bone with loaded resistance exercise or body weight, right? That's still a load on the muscle, on the bone. For women, osteopenia, they're at higher risk as they age. Genetics play a factor in that, but resistance training be a key aspect for that. Repeated resistance training causes the protein or myofibrils inside to grow thicker and more numerous. We know tendons and ligaments and other connective tissue become thicker in consistent resistance exercise. And then with that bone adaptation, that physiological stress activates osteoblasts, which favor bone deposition and or bone growth or preservation, right? Sometimes that's not about increasing your bone mineral density, but it's about maintaining or slowing that decline of, especially as we age. So cardiovascular training, we're trying to implement endurance and activities that they're doing at home up and down the stairs. So it's not really endurance like I'm going to run a marathon, but it might be pertinent to their situation or pertinent to their current physical fitness level, excuse me. So aging, again, we talked about this VO2, where there's a decrease in VO2 because we saw a decrease in cardiac output, right? 50% of that coming from the stroke volume, which we talked about before, and then a decrease in that AVO2 difference, right? The lack of blood flow, the lack of capillary beds with inactivity over the course of aging is going to decrease that AVO2 difference. So again, just some facts. VO2 is 2 times, the decline in VO2 is 2 times faster in sedentary than active adults. Again, regular physical activity lessens that VO2 decline. With consistent, there's been no decline in VO2 over a 10-year period, which is pretty convincing evidence, especially for somebody who's, and those longitudinal studies aren't intense. If you think about it, they're not requiring vigorous intensity for you to maintain your VO2 over 10 years. It is some sort of light and moderate, but it's continuous, right? It's consistent exercise. We know that other factors reduce VO2, such as genetics, increase in body fat, right? So we know when we're doing comparisons of VO2, we take into consideration kilograms or body weight, right? So increase in body fat is going to change that. We see a decrease in skeletal muscle, so or decrease in our ability to obtain, or decrease right in surface area of the capillary beds. The decrease in skeletal muscle is going to prevent us from maintaining or preserving our VO2, and decrease in physical activity. So again, why endurance train? So it's going to reduce that body fat, which will preserve our VO2. It sensitizes the body's tissue to insulin, so becomes a big player in adjuvant therapy for diabetes. It lowers blood sugar levels. It's going to boost our HDL, lower our boost our HDL, which is our good cholesterol. It's going to lower our LDL, our triglycerides, again, improving our bio-age, correct? We see improved mood and sleep. And then the big key one for older adults is really decreased depression and anxiety. They're going through changes in a lifetime that as they're aging and they're getting from 70, 75, they're losing friends, they're losing spouses, they're losing independence in the activities they once used to be able to do. So it's this constant battle, I think, with some of this depression and anxiety that we see most benefit from with the older adults. A little bit about flexibility. It arguably could be termed connective tissue fitness, right? It provides cohesion and internal support. We know our bones, ligaments, and tendons and cartilage. We're going to play a role in that. But however, as we age, this tissue becomes more dense and rigid. So if it becomes more rigid, we have less flexibility. We're changing our gait, right? If we have less flexibility in our ankle, we can't fully dorsiflex, or we can't fully plantar flex. We're not getting the same mobility and the same kind of gait out of that. Reasons being it's less hydrated, and then there's more collagen, and then less elastin, right? So it's becoming more rigid. This joint stiffness, again, we talked about cannot dorsiflex the foot. It's going to lead to falls. If I can't pick my toes up all the way, they're going to catch on the floor, and I'm going to be more predisposed to falling. So flexibility, ankle mobility is going to be huge in some of that fall prevention. Here's a summary. Take a look at it. All good stuff to consider when you're looking at your exercise prescriptions, where your clients falls in those areas, and how to either improve them or slow them down. So there's overwhelming evidence, right, that we know that exists. We know slowing these physiological changes is imperative. Optimizing age-related changes in body composition. So that body fat and muscle mass composition is going to be key. Promoting psychological and cognitive well-being. We talked about depression and anxiety and mood. Enjoyment for them is huge too. Our ability to manage chronic diseases with exercise, and then reducing this risk of physical disability and increasing longevity and independence, really. Take a look at this. Pretty cool. I think he's still alive. Disclaimer, if you will, I don't think he has an actual birth certificate. So we don't really, I think there's these two guys actually in India that are going back and forth on, I'm the oldest runner, I'm the oldest this. One of them, I think he's, as of almost this week, I think his birthday's in April, would turn 109. But he was running at the age of, I think, 89, to overcome depression. So his wife and his son died tragically in an accident, and he took to running to kind of, he found that as an outlet for them. I think his best marathon is 5 hours and 40 minutes, and I tremendously commend him because I can't run more than 2 miles at the moment. Also, update for all of you guys. I did in fact share my UCL for some of you guys who I think were asking in the midst of some of that transition stuff with strength and the lectures with Matt. But I don't foresee myself running a marathon. Kudos to him for running it on. I think the best example with this, though, is it's not too late to adopt some different lifestyle modifications or things that we might find or older adults might find that they enjoy. It's really never too late for them. Something is better than nothing as long as we can get them to avoid sedentary behavior. All right, we're now to the fun stuff. The latter end of this, we're going to talk about exercise testing and exercise prescription for older adults and considerations to have in mind. So for exercise testing, it's going to look a lot different than everything that we've covered so far in the course up to date. So our graded exercise testing, that was with our Bruce, which is a max effort, some of the sub-max field tests that we did, like the George Jog, or even the max field test that we did, the Cooper runs, aren't going to be necessary in this population. The Rockport being probably the exception. It's a very low to moderate intensity kind of test. But most older adults really don't require an exercise test to the standard that we've taught them so far prior to initiating in any sort of moderate intensity physical activity program. If you're doing those kinds of clinical tests or more laboratory tests, the workload should be light, so less than 3 metabolic equivalents, and those increments would really only be about 0.5 to 1 met per workload stage. So if we did the Bruce, we would want to calculate how many METs it's increasing per stage. Right, we're not going to do the Bruce, but if we're looking at that, we can compare to what the MET increase would be for that and how that would translate into making maybe a slower speed and a lower grade kind of workload graded exercise test for an older adult population. Considerations again, cycle ergometer rather than having them on the treadmill. We talked about gait and increased risk, decreased flexibility in the plantar flexion, dorsiflexion, which might put them at risk for falls. In this population, treadmill handrails may be necessary. It changes their workload, so you might not do actual estimated VO2 for that stage. You might actually just do time for total tests, like how long did they complete, and look at change scores over time. Safety, again, is going to be #1 key. So if you have somebody that needs handrails and you're looking to do one of those tests, maybe that's not the right mode to do exercise testing for them. Again, considerations for grade rather than speed changes, especially when you have somebody who has gait or balance issues when you move up the class rank for aging. So 60 to 65 may be different than 75 to 80. So just be cognizant of that. The oldest segment, they have an increased risk of mortality or cardiovascular event happening during that exercise testing. So anyone who's free from those symptoms should be able to initiate that light intensity, again, less than 3 METs without undue risk. What we see take hold in this population is more of these physical performance testing, replacing some of those clinical treadmill kind of delivery or batteries of testing. It assesses that functional status as opposed to performance status, or I guess performance status as opposed to clinical outcome status. These physical performance tests require little space, little equipment. They're very low in cost, most of them. They can be administered by lay or health professional personnel with minimal training, so it doesn't take too much to do them, especially when you're working at senior centers where you might have staff on hand as opposed to an exercise physiologist on hand. And then they're considered extremely safe across the board. They're not rigorous. They should be light to moderate in intensity anyhow. Here you can see the ACSM recommends a few. There's a senior fitness test, short physical performance battery, a usual gait speed, 6-minute walk test, and then a continuous scale physical performance test. The one we're going to look at today and really through this week of the lab is a senior fitness test. Some of you guys might have done this in lifespan and motor development with Dr. Goodway. But it's the 7-item 30-second chair sit to stand, 30-second arm curl. There's an 8 feet up and go that tests balance. The 6-minute walk test is included in that. There's a 2-minute step test, a sit and reach for flexibility, and then a back scratch, all that have normative scales for each. It's not a very long test. Again, there's performance ranks, percentiles of age-based norms. There's fall risk norms or disability risk norms in that as well. What this will look at is physical performance across a range of age groups and ability levels. Why we choose the senior fitness test, at least in this class, it's comprehensive, so it contains all major fitness components associated with independent function. It looks at a wide range of abilities, or to assess a wide range of abilities, and classifying them in that. So there's frail to independent or fit to elite. It's usable in a lot of field settings. So again, minimal cost, minimal space, minimal equipment, minimal training as well. And then there's those performance standards that are comparable across others. So the I'm going to pause there. The senior fitness test is actually going to be what you guys analyze for your lab. And then you'll get a case study. You'll look at all their senior fitness results, and then you'll be able to prescribe. So I'm going to pause there. We're not going to go into detail in this lecture. That'll be up to you guys to read the overview and all the tests and then analyze the video that I proposed for lab, which we'll cover at the end of this. But just so you know, we're going to touch back on the senior fitness test. But right now we're going to jump into more of the nitty-gritty of prescription and considerations for older adults. Here you can see the ACSM fit recommendations, so frequency, intensity, time, and type. It's a nice place to look at it all at once. When we think about prescription, we have to take several psychosocial, environmental factors into consideration when we are prescribing exercise to our clients that might be in this age category. Some of the behavioral strategies, such as social support. Are they somebody that has some depression? Are they somebody that thrives in group settings? Are they somebody that needs, maybe they're home alone, right? And their grandkids or their kids don't live in this area. So having some way for them to reach group fitness classes or to reach one-on-one training with you might be what they need, right? They need that social support as a pillar of their exercise prescription. Another being self-efficacy. We know we kind of thrive on this no pain, no gain. We don't feel like we're doing anything unless we're sore or we're hurt. Really the opposite in anybody that's in general population, because they don't know the pain or the soreness associated with exercise, and it's a learning curve for them to understand that, and it's up to us to kind of build that self-efficacy within that. So to harp on that slow and low is huge. For somebody who hasn't done regimented exercise, building on maybe one set where they can complete 10 reps for a week or two builds on that self-efficacy. Hey, I actually can do this. I can understand this exercise without having them do 30 reps by 3 sets or 10 reps by 3 sets all at once. Also, there's considerations for musculoskeletal injuries as well, but that self-efficacy piece is actually going to go a really, really long way in them actually coming back to you. The ability to make healthy choices, so providing them the right education about warm up, cool down, hydration, the sores that come with exercise, the technique that comes with exercise, and kind of normalizing maybe this change in things that are happening in their daily activity. And then that perceived safety, right? We talked about technique. Coaching them through that, the rapport that you build with them is actually going to go a long way in perceived safety. They're going to trust you in that one-on-one session, and making sure you're covering exercises with them in that one-on-one space before they go home and they do that. Or if you're doing neuromuscular training, that you're doing it supervised one-on-one and not having them do that kind of exercise at home where it might put them at greater risk. All of these enhance participation in a regular exercise program. I cannot harp enough on that self-efficacy, even if you know that they can do more. Starting them off at what they feel they can do is going to go a greater distance in having them actually come back to your exercise session or come back to your training program or your community center to want to do more. Again, providing regular feedback, that positive reinforcement, other behavioral and programmatic strategies are all going to go into enhancing adherence. They want to just talk to you. They really just want to share their stories, have somebody to talk to. So I'm going to add that one in there, I think, as opposed to just positive reinforcement and those behavioral aspects. Being someone that they can chat with during their exercise session, they're just going to want that outlet most of the time. I think I had one guy in my old job as a personal trainer when I got out of my undergrad. He came in and we just told jokes the whole time. And like he would come back, he did work, he did a lot of balance work. He did Tai Chi, I think, on his own like 3 times a week. But he had diabetes, a lot of sores on his feet, and resistance training for him was crucial. But his enjoyment in that session kept him coming back, which it's funny to think like, hey, I could write the perfect program, but if he can't enjoy it, uh, what we don't have a job then, right? They're not going to come back for programming. So again, snapshot for the recommendations: aerobic 5 days a week of moderate intensity activities. So we'll look at that 5 to 6 on a 10-point exertion scale. 3 days a week of vigorous intensity for aerobic, which would be 7 to 8 on a 10-point exertion scale. Again, duration being 30 minutes up to 60 minutes a day, or that combination of moderate and vigorous, right? These activities shouldn't impose orthopedic stress. Walking, swimming, stationary cycle are good examples. If you're looking for impact training and things like that, there's a lot of research out there looking at the pros and cons of that. Again, supervision and safety is one of them. When we think impact training, it's not going to be the same kind of impact training for them, right? So normalizing ourselves, if we're looking to work within this population, diving into more of what is safe and what counts as orthopedic stress and what doesn't count in older adult populations. Strength training, at least 2 days a week of moderate or vigorous. So they recommend for beginners that light range, 40 to 50% of a 1RM. This population, you might not actually be taking them through a 1RM protocol. You might do a 3 to 5 or a 10 rep. Again, it's not about maximum strength. For them, it's really going to be about moderate, light to moderate exercise at a higher rep. Those 10 to 15 rep ranges is crucial in this population. So moderate to vigorous is that 60 to 80% of 1RM. You might have to do an estimation of that with getting that 3 to 5 rep max again. Or those, if you're looking at exertion scales, moderate's about 5 to 6 again. Vigorous is about 7 to 8 for that resistance training on that exertion scale. 8 to 10 exercises involving all major muscle groups if we're doing 2 days a week for full body. Flexibility, again, at least 2 days a week of moderate. That mild exertion, again, should be about 5 to 6. It shouldn't be sharp shooting. Static stretching is recommended post any sort of slow motion physical activity. So if they've done a walk, having them do static stretching after, something where the blood flow is going to the muscles, and then they can do that static stretching after. A good place to do it again is after water aerobics or strength training or their aerobic sessions to really get that stretching in there. Lastly is going to be balance and proprioceptive training. So this is going to be more for your frequent fallers or individuals with mobility problems. So if you have somebody on the senior fitness test who is in that disability range or that fall risk range, this is going to be what you want to add to their prescription program as well, according to the ACSM. So neuromuscular training performed 2 to 3 days a week, effective in reducing and preventing falls. This doesn't have to be separate from your strength training. But you're going to look at different exercises. So if you're doing 8 to 10 all major muscle groups, incorporating neuromuscular training into those could be multi-joint exercises that are working on that neuromuscular training, split stance exercises under your supervision, right? It doesn't have to be a 2 to 3 day training session on their own. It can be complementary to their aerobic training or complementary to their strength training, but it has to be put into consideration and planned for in those sessions. It just can't be, oh, they're doing resistance training, so it's working on their neuromuscular training. That does not cut it, especially for these individuals. So it's getting creative on some of those multi-joint exercises, maybe banded assisted squats or split stance assisted lunges where they're working on that unilateral plus balance, things like that. So with prescription, you're going to do some sort of performance test, right, or exercise test or baseline assessment of where your client is at, right? Asking yourself what type of information are we getting is going to be key to moving forward. So endurance training. So what type of information, right? So we've got a 2-minute step test, which is going to show us endurance. You could also put the 6-minute walk in there. That's going to be your aerobic or endurance category. We're not actually going to do that for lab, but that's where that would go. You've got your strength component, so your chair stand, so your lower body strength, and your arm curl for upper body. Then you're looking at flexibility. You've got chair, sit, and reach. So looking at hamstring flexibility, low back flexibility, right, or pain, and then your back scratch test. So shoulder range of motion, which is pertinent to anything overhead. they're living at home, this backstretch test might be the difference between being able to reach up into the cupboard above and getting flour to bake food or whatever, or carrying those groceries and moving those things in a different space. Last thing being the balance, right? So we've got our 8 feet up and go. So that's up 8 feet around the cone and back is going to really work on that dynamic gait and balance issues. We get all our results. We've done all the testing. We got all our results. So what do we do with that information? If it's necessary, we can compare that normative data, where their percentile rank is, to those. We can say, okay, here's people your age and gender. This is where you fall. It's a great place to be, and we're going to maintain. Or it shows us that, hey, we have to improve on some stuff. And it allows us to see what we should be focusing on. So you've done, most likely this will come before doing that senior fitness test, but knowing your client is crucial. So you're going to do your medical conditions, well, your medical history. You're going to look at conditions, injuries, recent injuries, and that you're going to continue to update along with medications. Family history, again, we know genetics affects aging and what's going on. Aside from all of the paperwork that you're going to do with them and the initial intake they're going to do with them, that will be the same across general population, right? You're going to ask a lot of different questions to understand how much are they currently exercising, okay? Distinguish exercise, distinguish physical activity, right? We know they're going to be different. So are they currently exercising, doing planned physical activity or planned repetitive motions, strength training, resistance training, aerobic classes? This could include activities of daily living, but just be cognizant of the effort that they're putting in. Is that physical activity or is that exercise? Because they're both going to count towards their overall activity minutes. But for you to know going forward where they're going to need help. What kind of activities do they like? Somebody might actually hate gardening or yard work or things like that. Are there other ways for them to incorporate daily activities that are going to be more beneficial for them? Is somebody going to need that social support and want to do group classes as opposed to having to go to the gym, learning the exercises, doing it on their own? Some people might thrive better in that avenue. I know some of you guys know that you work better alone, jumping into the gym and doing what you need to do. What do they want to do? Coupled with what do you feel they need to do, right? It's your ability to merge those two things together. For somebody who's got lower orthopedic issues and they really enjoy group activity, putting them in water aerobics might be a really good outlet. Something that's incorporated with what they want and what you feel they need to do. And then when do you do it by and where will you do it by? That's going to be where you start, right? They're going to have some goals in mind, some of them coming from their doctor, some of them coming from personal. They may have a longer term goal. Hey, I want to reduce my blood pressure medication. That's a huge goal, right? Being able to set up both the short term and the long term goal for them is going to be your job as an exercise physiologist. So I want to be able to take this trip with my kids. That's my long term goal. Okay, break that down to how we know how to plan those, make it time sensitive, measurable, achievable, right? As opposed to saying, yeah, I want to take this trip. I want to have strength to take this trip, right? So I'd like to incorporate a day of resistance training a week to help build on that. Those kinds of things where we're looking at those short terms. So for endurance, we want to make it fun, right? Daily activities, again, mowing the yard, gardening, laundry. A big one is walking the dog or incorporating family into that. This is really where you can get creative. Some things that you know your parents might be doing, especially right now. We're in such a unprecedented time. A lot of people are getting creative in the ways that they're exercising and the way that they're getting endurance training in. So that coupled with what they enjoy is going to go a long way. For strength, again, we want to focus on low weight and high reps, making sure we're emphasizing breathing and the proper breathing techniques, right? Their blood pressure may be elevated in some clients. Their arteries and their veins, again, are undue to the stress of aging. It puts them at higher risk for rupturing blood vessels at smaller, minute levels, etc. So breathing is going to be huge. Hand grip, again, knowing somebody who has arthritic complications in their hands, thinking about building on that grip strength, but not putting them in the compromised position. So if you look to the picture from hand grip to your right, somebody who has arthritic issues in their wrists and their hands, supine dumbbell press may or may not be safe for them depending on the severity of that grip strength. You can have them work on grip strength, but in a safer position. This might put them at risk for weights falling on their face, etc. So if it is that, and you want them to do maybe an incline push-up instead to work on their chest, or you have them do an upright banded chest press, where they're working on that grip strength, but they're not compromising their risk for injury. Band work is huge. It's safe, it's easy. They can take it anywhere they go. And it's really easy to universally learn in terms of if I set them up, I can give them a plethora of exercises without them having to go to different machines and do different settings and all of that. Here are just some examples. You can see they're innovative with the Kansas soup. We talk about it all the time, but it actually happens in real life. And I'm sure you guys have been doing some of your own things right now to add weights to what you've been doing at home, because we all don't have fancy dumbbell sets or racks and stuff. So I think this is a really neat time for you guys to indulge in that and how you would get creative in prescribing for older adults and stuff. Some of the considerations for ACSM is that initial training sessions should be supervised and monitored. Again, who are sensitive to the special needs of older adults, which should be you guys at the end of this. There are some benefits for power training. So we know that we have a significant reduction or faster reduction in power as opposed to strength, right? So if insufficient power has been associated with that greater risk of accidents and falls. So what they recommend is bumping up that muscular power, including single and multi-joint exercises, using light to moderate loading, but anywhere from 6 to 10 repetitions with a higher velocity. So you're pushing that 30 to 60% of your 1RM. You're going for power as opposed to overall strength. Again, individuals with sarcopenia should increase the number of muscular strength before they're engaging in that aerobic training. So if I'm losing muscle mass and then I'm going out for a walk, muscle mass and strength, right? I'm going to decrease functional ability, which might put me at greater risk for aerobic training. So somebody comes in, there's a significant reduction in strength and muscle mass. Get them started with a basis for muscular strength before they're jumping into any of this aerobic training or moderate to vigorous aerobic training. Here's your rate of perceived exertion, again, on that 10-point scale. You want them anywhere between that 5 to 6 in that hard range or that 7 to 8 in really hard range, again, for moderate or vigorous. Your beginners are going to be anywhere probably from that 2 to 4. And this allows them to understand the kind of workload that they're putting in, and it allows you to help them progress, saying, we've been doing this weight and you went from a 7 to 8 and now it's feeling at about a 3 to 4. This is a great plus for us to increase reps or increase weight at a marginal or smaller level, incremental level. Next thing we're going to jump into is flexibility. So with this, you want to think about, go back to their medical history. Are they presenting with any injuries to certain joints? Do they have limited range of motion in those joints? Again, this is where you want mild tension, not a sharp shooting pain. Are they presenting with osteoporosis? Are they presenting with osteoarthritis in certain joints? We'll talk a little bit about more considerations for rheumatoid arthritis, which is more of a neurodegenerative disease. Another thing you want to think about is, do they have any arthritis in the cervical neck region, thoracic spine, the lumbar spine? Any of these, you want to take more precaution and not hyperextending any joints, keeping them in a slow, controlled movement through those joints, and not over stressing the head or neck because it'll make it worse. Again, you want them to hold to mild tension. A lot of times, if they are at risk for injury, or fall risk, having them stretch with chairs, mobilizing stretches that are on the ground for certain individuals. We know as the older they get, they may have severe difficulty getting up and on, like down to the ground and up off the ground. So you might have to improv and come up with some creative stretches in the chair, which I'm going to urge you guys to get creative with that with your case study prescriptions. So to break those down even further, for stretching considerations, so osteoporosis, avoid stretches that place excessive stress on the cervical region, the upper neck. So we tend to just pull our hand over our head, pull our neck over opposite side. Something you'd want to avoid high stress in with clients that have osteoporosis. Osteoarthritis, any weight bearing or load bearing on the joints that are affected. This may cause pain. So for knee osteoarthritis, if you're having them do an unsupported standing quad pull may not be as advantageous as a let's sit them down and do a hip flexor, like a quad stretch seated in the chair, different things like that. In a seated or lying position. So sometimes if they do have ease getting down to the ground and getting back up, there's some side laying quad stretches or things like that that can be done. Just know your client and justify that I know my client can get on and off the ground. Lastly, the rheumatoid arthritis. It's a neurodegenerative disease. A lot of times there's flare-ups. It's an inflammatory stage that happens. They're in a severe, they're going to know that they're in a severe flare-up. They're in pain. It's a lot more rigid. It's a lot more stiff. Don't stretch at all during this stage. And that's going to be a continuation of monitoring of, hey, I know my client is presenting with this when I first do their intake. That's a question then that I'm going to ask before every session that I have with them. How's your wrist feeling, or how's that doing, before you take them through stretching. They should be pain-free again in the hours following, 24 hours after that stretch was performed. So all of a sudden, let's say you have them stretch. If there's severe pain in the next 24 hours, probably not a good thing. Something that you would avoid down the road. They may already have fused or limited range of motion, so just be aware of that when you're taking them through certain exercises that you're trying to work through, understanding that they may not have that full range of motion. Breaking down neuromuscular training, there's different ways that we can stress this. There's different ways that we can implement this in their own exercises or in the exercises that we have them do during strength training. What we can do is progressively change the stance, or gradually reduce the base of support under your individual. So we know we've got 2 feet together. The wider that stance is, the more balance and stability that I have. So the more narrow that my feet become, the closer that they get together, the less balance that I may have. So you may start out with a wide leg squat and then move them in a little bit. Moving them from 2-legged to semi-tandem, which means semi-tandem is kind of like your lunge stance, right? So the wider set that your lunge stance, the more balance that you have, the more inline your lunge, the harder that's going to be. So if you're moving them from feet together to semi-tandem, having some sort of support, they can tie a band around a water pipe in the basement and use the band as upright support, kind of like you would with a TRX. So they have a reduction in weight as they're moving in that semi-tandem position, and then you'll gradually build them off of that upper body base of support. You can move them into 1-legged stands. So either feet together, a lot of inline walks help with this population. It becomes increasingly more difficult for them to do. Dynamic movements that protrude the center of gravity, so you can have them do the tandem walk, so your inline walk, right, and then point, circle, turn, and come back on that straight line. You can also have them do an inline walk where they're holding a weight close to their chest, and then you're going to move that center of gravity as you say, let's say we have a 5-pound weight. Anytime that you move that weight away from your body, the heavier that weight's going to be, the difference, there's going to be a significant change to your center of gravity. So you have to be able to do that movement while extending your arms out, changing that center of gravity and back in. I've done this on the little air flex pads with one of my clients previously who had severe balance issues. He was doing single leg stands on the pad. After he exceeded 30 seconds, what we started to do is have him, okay, 30 seconds on the pad, and you have to do reach out with the ball and back in, all while maintaining his single leg stand. Reach out with the ball and back in. So it changes their center of gravity. It adds more dynamic movement, something that they might actually be doing if they're in a single step coming up the stairs or the basket of laundry. That's going to pretty closely mimic what's going on there. They've got different load or center of gravity with support in one leg as they're moving up the stairs. Again, postural muscle groups, heel stands, toe stands, so that dorsiflexion, really getting them up on their toes, increasing that mobility. You can reduce sensory input, but making sure that you're there in all of those supervised sessions. These are going to be things that you don't do at home with them. Depending on their like or dislike for group classes, Tai Chi is actually really, really well enjoyed by a lot of them. It's slow movement, it's balance. It really helps them out tremendously. So if they have access to it, maybe go with them the first time to try it with them, so they kind of get a little bit more comfortable with you there. So again, balance, you've got heel to toe walk. You can see on the right there, you're going to walk on your heels or walk up on your toes, down and back. You've got toe stands. You can change that air flex. Again, if you have them working at home doing some exercises for mobility, use the chair. Have them use the chair even in sessions with you so they can get used to it. Changing again the center of gravity that they might have with that. How do we progress? Know your client. Start slow and low with high reps. They're adjusting to all of this as well. So it's not like, oh, we've taken 3 weeks off, we're going to jump back in and get kind of close to where I was on the squat or the bench. Know your client, what weight, what activity level, what enjoyment, what are their goals, right? Do I need to do higher rep, higher velocity if they're losing significant function? But starting slow and low is going to really help them build self-efficacy here. If I can start one set by 10 reps and they can complete it and feel like they can complete it, we're going to come back, do it again. But if I throw them in at 3 sets of 10 reps at a really high weight, they're significantly going to probably say, done, bye-bye, this hurt me. Build up again, allowing them the time. Their adaptations are happening a lot slower than they happen in us, so it's a slower progression. Listening, having them understand how to listen to their body. Increase weight when reps exceed that 10 to 12 rep range, depending on your goals. You could also fudge that to be when it gets greater than 15 reps, and then bring them back down to 8 to 10, build them to 10 to 12, 12 to 15, and then adjust the weight, drop back down the reps. One good rule of thumb for them, if you can't talk, you're too high of an intensity. If you can sing a song, you're too light. This a little bit more with aerobic, but it could also be useful in something like resistance training. Last thing for injury prevention, know your client, know what range of motion issues they have, know what medical history they might have. Are they diabetic? Do they have to check their blood sugar before, during, and after a session? Do they have to have that kind of access on the floor? Making sure that they're warming up and cooling down. Super important in this population because their bones and tendons and ligaments are a lot stiffer. So the more that they can warm up before a session, the better they're going to feel. You'll see that with this. They're like, oh, I just got up and started moving in the morning, and I feel like I'm much looser throughout the day, and this and that. So movement for them is key. Getting them to move, getting them out of that sedentary behavior is actually going to help prevent injury in that. Cool down is just as important. Those static stretching, safe static stretching following exercise. Again, your progression starts slow. Talk about breathing we did. Avoid that lockout of joints. They're going to have some hypermobility in some of those joints over time, right? Like their tendons and ligaments are wearing out, so they're going to have maybe more hyperextension in the elbow joint. Just make sure they're not locking out those joints. Hydration, again, in this population, a lot of them are on diuretics, a lot of them might be on other medications and things, so coaching them on adequate hydration for before, during, and after. I would also say fuel, make sure they know that they're eating before they're coming to an exercise session, or know how to eat before coming to an exercise session, what they should be doing after. And it's not our whey protein kind of like, oh, they need pre-workout beforehand. They're very bird kind of eaters. They're very small, their meals aren't that big. So when they're coming into exercise with you, that's something you also have to take into consideration. Are they eating before my session? If they aren't, how am I adjusting my session? Am I even continuing my session if they haven't eaten? Or am I going to have something on call? Hey, why don't you sit down, eat this bar? We'll start here in about 15, 20 minutes, and we'll get you through maybe half of what I had planned for you today. So really knowing that, especially in this population, they don't know the normalcies with what we do with exercise. So it's up to you guys to take the time beforehand to figure out where their base of knowledge is and what you need to help fill in so that they can be successful. And that way you can prevent any events happening during your session. Last thing to note, we talked about this in all populations, but anyone on a beta blocker, so with the OLOL, I guess, any medications with that, here are kind of your typical ones. They help manage some sort of cardiac arrhythmia. They're taken usually after heart attacks, hypertension, or for angina, or that chest pain, angina, if you will. It's to help reduce the amount of stress on the heart. What happens is it's going to reduce that heart rate during exercise. So you have nausea, slower heart rate, hypotension, fatigue. So if they're on a beta blocker, their blood flow is going to be a little bit different from supine to standing. So being cognizant of how you're moving them through certain positions or how slowly you might progress them through those positions. And then lastly, not using heart rate to indicate exercise intensity. That's where the breathing test helps a little bit more and that kind of stuff. So we wrapped up. Thanks for hanging on. Your lab this week will revolve around the senior fitness test. What you're going to do is review the senior fitness test overview. I know we didn't talk about it. Some of you guys should have already covered it. You'll read through the instructions. What then you'll do is watch the video that I posted for the senior fitness test video analysis. You're going to watch the video and you're going to score the results of the individual in that video. You'll have a template to fill out for their scores. You'll fill in their normative data with the score sheet, and then you'll review a separately assigned case study that I'm going to give you. So you'll have watched the senior fitness test, and I'm going to give you a case study of John or Betty or whoever. They're going to have their senior fitness test results and their goals and aspirations, some of their medical history, and then you'll complete the rest of the lab document and exercise prescription for your case study, which will all be up there. Thanks again. You guys enjoy the rest of this week.